Well, good afternoon, folks. At least if you're on the East Coast, good afternoon. Brandon Garrett with the National Minority Quality Forum, hoping that you're having a good Friday and hopefully a good start to a good weekend. As usual, we're going to do our best to try to help educate you in the health and healthcare space today. But before I actually give you all a little bit about the program, excuse me, I just want to let you know that it's going to be a very interactive program. And so if you have questions that you'd like to ask, please put those in the Q&A box and our moderator, Pam Barnes, will get to you. And then if you want to sort of have, for the good of the order, topics or anything you want just the general audience members to be aware of, please put that in the chat box and we'll check that as well. But like I said, as you all may know, I'm Brandon Garrett, the CEO of the National Minority Quality Forum. Today, we're going to be talking about amplifying patient voices for health equity in the wake of the Inflation Reduction Act. This, I think, is going to be a great topic, but it's also a prelude, I believe, to the conversation that I've worked on with Pam during our National Annual Summit on Health Disparities that's going to take place next month, I guess, in 2 Mondays and Tuesdays. So if you're interested in that, we'll put a link about registering for that. And I think I've said this woman's name a good 4 times without introducing her. So Pam Barnes works at BMS. She's actually been working in the healthcare space for some time. She's a member of our NMQF's corporate roundtable. So we discuss these health policy issues sometimes at length and nauseam, sometimes just in passing, but we really try to think through what we talk about. Now, one thing I want to say about Pam and the folks that she works with, that she's always looking at putting patients first. And so I think that's what this conversation will center on. So without further ado, I'll turn it over to Pamela Barnes with BMS.
Well, thank you, Brandon, for that warm welcome, and good afternoon, everyone. Again, I am Pamela Barnes. I am the Director of Federal Strategic Alliances at Bristol Myers Squibb, and I'm delighted to serve as a moderator for today's session. We'll hear from 3 distinguished panelists who are all experts in their field. They will share their insights, experiences, and tips on how to amplify patient voices as the Inflation Reduction Act, or IRA, is implemented by the Centers for Medicare and Medicaid Services. So with that, let's jump right in. We'll start with Stephanie Dyson. She is the Senior Vice President and Head of U.S. Policy and Government Affairs at Bristol Myers Squibb. Stephanie, can you explain for the audience what the Inflation Reduction Act is and where we are in terms of implementation?
Great. Thanks, Pam. Nice to be here. So thanks to NMQF for hosting as well. Let me start with the IRA and what is it? CMS, sort of Centers for Medicare and Medicaid Services, they're currently implementing the IRA, or Inflation Reduction Act, which was actually signed into law in August of 2022. There were 3 major sections to the IRA. There were healthcare provisions, climate change provisions, and tax provisions. Today, we're just going to focus on the healthcare provisions. So if you need additional information on the other areas, we're certainly happy to follow with you on that. With respect to healthcare, there were 3 main areas that we're going to cover today. One is drug price setting, which some refer to as negotiation. Secondly, inflation rebates. And then lastly, the restructuring of the Part D benefits. The drug price setting, for the first time, the federal government is required to negotiate, and I use air quotes, prices for what they consider to be high-cost drugs covered under Medicare. Last August, CMS announced those top 10 drugs covered under the Part D, as in dog, plan. In subsequent years, they would then add on Part B, as in boy. And they are now engaging with various drug companies. BMS happens to be one. And any prices that will be negotiated or set will be effective beginning 2026. It's interesting to note that some of the products, like the BMS one, even though it's top on the Part D, as in dog, list, it's not high cost. It's actually there because of high volume. And we're talking today about patients and the benefit to patients. So that's an example of a drug that was selected, but its position is based on the efficacy of that product and the fact that it's preferred by physicians and patients. Secondly, you have the inflation rebate, and this is a provision that requires drug companies to pay rebates if a drug price rises higher than inflation in certain circumstances. And then lastly, it's the restructuring of the Part D drug benefit. So there's a $2,000 cap on the Medicare Part D out-of-pocket spending. BMS and others believe this was a welcomed addition and a welcome change to the Part D benefit design. And it includes other new manufacturer liabilities. If we had our way, the industry would have had that $2,000 cap even lower. So where there are parts of the IRA, like the patient out-of-pocket and restructuring drug benefits that we're more than supportive of, there are other areas such as the so-called negotiation that we think could have serious consequences for patients. Thanks, Pam. I think that sort of gives a high-level perspective.
And thank you, Stephanie, for bringing us all up to speed. Can you provide some color on the implications of the IRA, particularly on health equity?
Yeah, for sure. I think the first thing that comes to mind is the so-called negotiation area, because what we have determined is there is, quite frankly, a disparity in how small molecules or pills are treated versus the biologics or mostly infused. And we call that the pill penalty. What that is, in short, is that price setting begins after 9 years for small molecules, but after 13 years for the biologics. And even though it's 9 years for the small molecules or the pills, that selection begins 2 years earlier at year 7. And for biologics, it's 13 years, but the selection begins 2 years prior at 11. And so this, in our opinion, hinders actually the access that patients can have, especially minority patients, to the small molecules. And these are often the products that can help address and reduce health disparities. You think about the small molecules, they're often the oral dosage forms, they're often the medications that are stored at home or easily self-administered, and they're a convenience to individuals in the minority community, preventing sort of the need to go to the hospital or thinking about some of those other issues that minority patients face, such as, housing instability. And what about the areas where you don't have pharmacies or you have inadequate support from a social service perspective? So what we have tried to identify and point out to members of Congress and policymakers is this pill penalty, if you will. It really discourages companies from, if there is a choice or if there's an opportunity to have further R&D, we did not want a disincentive to disincentivize manufacturers from thinking about oral medications first. And so we consider it just a potential blow to patient access, especially minorities, by writing this pill penalty into the law.
Thank you for sharing that. And Donna, I want to come to you next. Donna Cryer is the founder and chief executive officer of the Global Liver Institute, the premier patient-driven liver health nonprofit operating globally. Donna, building on what was just mentioned, I'd love to hear your perspective on the IRA as a patient advocate and the importance of health equity as CMS continues to move forward.
Thank you so much for this opportunity to speak on this issue of really huge impact. We've worked successfully with the administration on issues of value in healthcare and several others. And so I know that the intent of the legislation and the intent of the package was to lower costs overall and to advance access in alignment with the health equity focus that the administration has had. Unfortunately, I think that the actual mechanisms that the IRA leverages will have well, I was going to say unintended consequences, but some of them are intended, but I think reflect a misunderstanding of how complex the incentive structures are in healthcare, and will have consequences for patients and caregivers and their families and communities that are not in alignment with the rest of the administration's agenda, and that's unfortunate. I also would say that you know, as Stephanie mentioned, there are parts of the IRA that have do reflect what many advocates have been asking for and working on for several years. I remember, you know, decades ago, talking about the dire implications of the donut hole, for example, and how many patients wouldn't make it across to the other side. So to see a $2,000 cap on out-of-pocket costs really is the reflection of a lot of years of advocacy, and so that provision and that of trying to lower the premium costs for the affordable insurance available and coverage available through the Affordable Care Act are things that are quite laudable. But as Stephanie said, the negotiation part is problematic. You know, I wrote in law school many years ago now on mediation when there are power imbalances. And this is certainly a situation that I never contemplated because of the outsized power imbalance of the federal government in healthcare, and the way that this has been set up during the IRA really is something as a lawyer, I find really just untenable, and you know, would be in this sort of unfair takings. As a patient trying to participate in this process, we feel very small between these large giants, and although I minored in economics or had a secondary concentration in economics at Harvard, most patients and patient advocates did not. Neither do we have a spare economist on hand to participate in a meaningful way in this process, or to understand it and communicate it to our constituencies. You know, we've had to develop a lot of capabilities and competencies in health technology assessment and health economics and outcomes research, you know, since the early days of ICER, and also, but still, it's an incredible burden on 99% of patient advocacy organizations, let alone individual patients, to be able to weigh in a meaningful way and to contribute to this process as a partner, and in a way that we feel will have impact proportional to the fact that we are the ones who will bear the negative consequences of the you know, sort of skewed decision making that will result, and has already started to result, from the IRA. And so I think that's the overall takeaway, is that I know that the intent is noble, but the mechanisms that have been chosen to be deployed in this will have you know, potentially catastrophic negative impact for many patients and families.
That's helpful, Donna. And I just kind of want to tease apart a little bit. If you could dig a little bit deeper for our audience, just on the value of the patient voice when it comes to health equity, and when it comes to involvement with CMS.
Absolutely. For many years, having patient engagement in a meaningful way across sectors in healthcare, whether that's with the pharmaceutical industry partners, with health plans, with hospitals, with regulatory agencies, is still relatively in early stages. Many of us are the first patient ever to sit on different types of committees, or to have input at a very early stage of design in policies of all sorts. And I think that meaningful patient engagement in the healthcare benefits, coverage, insurance design sector is really sort of the final frontier, because we lack the point people to talk with people, have meaningful input at CMS the way we do at other agencies or in different parts of the healthcare sector. I know who to call at a hospital. I know who to contact at a pharmaceutical company, but across the healthcare payer space and health plan space, and most notably at CMS, who to talk to, when to talk to them, what information to bring, it has really been opaque. And so if it's this difficult for the most well-resourced organizations, and the most sort of well-staffed organizations, for organizations that serve primarily underserved or minority or marginalized communities, it really is next to impossible to add this to your workload, to find the expertise in the impact on your communities, on our communities, to be able to participate in a meaningful fashion. It's also, very, very rare to have advocates from diverse backgrounds who are available to speak, and to, it's a privilege to be healthy enough to be able to advocate. And it is a privilege to be able to have the time. Many of the patient advocates are doing it in a volunteer capacity, or certainly are taking time away from their own healthcare, their own time and families to do that. And so there are fewer people of color, fewer women, fewer of those who have jobs that they can't just take endless time off of, or obligations for not only their family, but perhaps other families, patients who are both patients themselves and caregivers to others in many circumstances. And so the difficulty in having competent, well-equipped patient voice is a struggle in and of itself, with the level of complexity and technical knowledge necessary to participate in this type of process. And so the difficulty in it is only amplified when you start talking about being able to have diverse patients able to sit in these seats and stay abreast of these issues. We have our Advanced Advocacy Academy to train patients in a host of issues, of course, across policy, value and reimbursement being one of them, because it was so rare to find training of advocates in that. And so, as one of the few leaders of color of an organization that has a large, breadth of types of disease and a breadth of patient communities, being very intentional about making sure that we recruit people of color and support patients who may need a caregiver with them to travel, or may need most of our materials are in as many as 13 languages, and we're exploring different tribal languages as well as perhaps the usual suspects of Spanish or French. And so being able to have patients equipped in their language, in culture, and then in these highly technical economic impact issues, it's very rare to be able to have patients who are able to do that, but it's never been more important.
And thank you for that, Donna. And you and your organization, the Global Liver Institute, has a long-standing relationship with the FDA, particularly when it comes to sharing the patient perspective. Can you give us a little insight on your experience with FDA as a patient advocate, and how does that compare with the recently held IRA listening session?
The experiences are very different. I have been a patient representative with the Food and Drug Administration for well over a decade, with the opportunity to sit as a voting member of multiple advisory committee, as well as a speaker and panelist on various workshops. And so there is a very formally recognized program of patient representatives within FDA of several decades now that is structured where patients are supported, and we have access to FDA staff who will teach us and take time to walk through FDA processes. There is consistent contact, and so it is very clear who you're working with. We've worked across several PDUFAs now to increase the number and diversity of patient experience tools that are part of the formal review process. We have examples of patient-focused drug development meetings, both with FDA formally and externally led, so that there are ways for patient experience to be brought into the process in a very collaborative way. And patients are compensated for their time, recognizing that it is an unfair burden to expect someone who's already living with or has survived a serious illness to be able to spend this additional time to ensure that the system works well. And so that helps the diversity of patients who it's possible to participate. And so if you compare that to what CMS has set up, their listening sessions are just that they're listening, or you hope they're listening. They're very passive. It's not a dialogue. There's not a mechanism for feedback and collaboration. There have been in the listening sessions to date, there are 3-minute limits and the limit on the number of patients. And so to be able to get, the diversity of patients in multiple senses, in the, where people are on their patient journey. Are they newly diagnosed? Are they in the midst of treatment, or are they experienced patient, or perhaps have survived and lived through? Those are very different perspectives to be able to capture. Have they been treated for their illness in a rural setting, a community clinic setting, an academic medical center? Those are different experiences. And as Stephanie had pointed out, having experience with conditions that are usually treated with small molecule drugs versus biologics. I am on on medications myself that have that across all classes, infusion, injectables, as well as small molecules. And so to be able to have patients who have that range of experience as well, to understand the impact of what it means to have to travel, in many cases, hundreds of miles, and to take time off work for infusions, versus how you do injectables as you travel, or the support and training is next to that, and the difference that is change in formulation to an oral medication, and having those choices within a class of drugs or available across a treatment, in many cases can make treatment possible or impossible for patients. And so being able to reflect the diversity of that experience is very hard to be able to deliver or capture in within the parameters that CMS has constructed. And so, we wish they had taken more lessons from their regulatory partners. It's one thing to say that, oh, it's different to do it within the federal government, but we've provided federal government examples to them, like FDA, of how to engage in meaningful ways with patients, and it is quite striking that they chose not to avail themselves of those models.
And Donna, on that point, what additional recommendations would you give to CMS on how they can improve patient engagement, as they continue to implement the IRA?
Well, I don't necessarily accept the continuing to implement the IRA, but that's perhaps another story. I think that what experience has shown in meaningful patient engagement is the long-term relationship building, to have understanding on both sides. It needs to be staffed in multiple folds, more than the staffing around inclusion of patient voice and patient insights and patient experience of the most successful models that I have seen often include patients, caregivers, people with lived experience in formal roles as part of the staffing. So it's not just sort of a one-off type of experience, but really is built into the way that the organization functions, and that the incentives for performance of the staff are also based on how patient insights and experience have been included. I think when you see even the experience of ICER, for example, and their evolution of creating patient advisory councils of standing and guides on how to work with them, and recognizing that there needs to be support given so that the type of economic analyses that most patient groups just don't have lying around can be created, are part of what CMS needs to do as part of its commitment to having the patient voice as a meaningful part of implementation, not just as a box to check off or something that's more performative than real and productive. And so I think they need to be really leveraging the details of the model that comes from research and regulation, and even I've worked to build a public policy institute in the payer space, and part of that was a disability and aging standing work group that helped to work on issues of both develop and design, but also to vet and get feedback before larger sessions, certainly well before even draft policies are put out for comment, so that they have a better chance of being right. I think CMS and others forget that patients are their greatest can be their greatest allies. We have this expertise. We want them to succeed. We want them to understand what is the best way and the most effective way to provide coverage for us. Patients are as good at finding ways to reduce costs and to provide care most efficiently than anyone, because we'd rather not be sick in the first place. We'd rather be home or at work or with our families or doing other things. We certainly didn't create all of our savings to be to use for healthcare, but for living our fullest lives. And so no one has thought more about how to be cost effective in healthcare than patients and their families. And so we deserve to be our expertise in that, as well as the clinical expertise on the experience of living with the illness, should be leveraged. CMS is missing out by not doing so in more formal and systematic and sustainable ways.
And thank you, Donna. And certainly the patient perspective is critical, and we need that two-way dialogue. It's essential for meaningful collaboration. I want to turn to Pam Traxel next with the American Cancer Society Cancer Action Network. Pam Traxel serves as Senior Vice President for ACS CAN, the advocacy affiliate of the American Cancer Society. And Pam, how has your organization engaged the IRA, particularly on the impacts to health equity?
So thank you, first of all, to the National Minority Quality Forum for inviting me to participate in this webinar today. So ACS CAN has been deeply involved in the negotiation and passage of what is now the Inflation Reduction Act, particularly with a lens on making sure that it can help us fulfill our mission, which is to end cancer as we know it for everyone. And those 8 words are pretty simple, but when it comes to the Inflation Reduction Act, I think we have a couple of key challenges. So as Stephanie explained, there's a bunch of different parts of this law. It's a really long law, if I'm being totally honest, and it's really complicated. And it's not surprising to anyone that when our government tries to implement something really, really big, it's super, super messy. So there are 2 things that I want to talk about that I think where the intersection of health equity and the Inflation Reduction Act meet. First and foremost is around the potential impact to innovation. So Stephanie talked about the pill penalty. There's an inflation rebate issue, blah, 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 blah. And some of that might not matter to patients, except for the fact that, building off of something Donna said, if you are a patient, or if you are on the audience and you are a caregiver of a patient, or maybe you're lucky and you're just a healthy human being, I think one of the things that we all know is that there will come a time when we will need to turn to a medicine in order to improve the quality of our lives, in the case of cancer, to save our lives. And it is devastating, and I think we all know about this, when you turn to a medicine and there isn't one. So I think we all, as human beings, have a stake in making sure that there is research and development in innovative therapies. And I think we all know, at least in the case of cancer, that there are not enough therapies to help save the lives of the nearly 600,000 Americans that'll die from cancer this year. I think all of them and their families would really like innovative medicine. And so I think we all have a stake at play in that. I also would say innovation is not just about the creation of new therapies, but it's really taking into account the individuality of each patient. So each patient, whether it's cancer or another disease, or maybe you're someone who has multiple comorbidities. In fact, cancer patients on average have not just cancer, but 5 other diseases that they're being treated for. So as you think about that and you're working with your doctor, they're going to tell you things like, oh, you can't take that medicine because you're on a steroid, or we're not really sure how those 2 things interact together. And you're like, well, should I cure my cancer, or should I make sure that my heart isn't in AFib? How does those 2 things work together? So really, when it comes down to the practice of medicine, you and your doctor are making very individualized decisions about what medicines you can put in your body, at what time, what you're going to eat when you're taking that. And as a result, this means that we need a wide array of medications for people for even the simplest of diseases. And I think that that's something that's sometimes not lost on people, but we really need to make sure that we have a lot of options. There are many patients who have relatively simplistic conditions that, because of another comorbidity, can't use existing therapy. And so while it might not be sexy to talk about some of these diseases, these are patients who are in need of research and innovation as well. The second thing about health equity is a really important part, and it really has to do with patient cost. So the first thing I'm going to tell you, and this is headline news, so everyone write this down. The Inflation Reduction Act does not actually say that patients will pay less. I just want that to sink in for just a moment. It does not actually say that through the negotiation process that patients will pay less money. And so the number one thing that ACS CAN is involved in is making sure that if drugs are negotiated, which they're being negotiated right now, that patients actually end up paying less. Because there are many situations in government where government saves money, but individual patients do not save money. And I think we all know that every patient could use a few more dollars in their pocket to not spend on healthcare. My last point is about the ability of this law to cap the expenses in Part D as in dog at $2,000. Now, this is a very exciting change for many patients, particularly in the cancer space and people who have chronic illness. They have a lot of expenses. So capping this expense is a big deal, except $2,000 is a lot of money to a lot of Americans, right? Nobody's really thinking about how they're going to afford that expense. So this law also allows patients to spread that cost over months. This is a really great idea, but it's really, really complicated. And I worry about patients in underserved communities where there aren't financial navigators, where literacy rates might not be as high, where there might not be as many healthcare professionals, for their ability to enroll in this program, which will allow people to better afford their Part D medicines, but only if they understand how to enroll in it and how it's going to work. And I'm here to tell you right now, it's really, really complicated. So we're all going to need to work together. But those are just some of the implications that we're concerned about with the Inflation Reduction Act and its potential impact on health equity.
And Pam, can you give us a little bit about what ACS CAN has done in terms of patient advocacy with the IRA and making sure that the patient voice is heard?
Yeah, this is a really important point. So when the law first got enacted, we did a lot of webinars with other patient advocacy groups to talk about what were all the various complex parts of this law. I think that was really important. And then each September, there begins a process where patient advocates and individual patients can offer comment both in writing and the listening sessions that Donna talked about. So we participated in those and actually allowed individual groups to sign on for that. I think, as Donna mentioned, this is a pretty dissatisfying experience. There's a lot of us talking, them listening, but no dialogue. And so I think one of the things that ACS CAN is really committed to, and we're working on right now, is trying to better capture patient experience with some of the products that are being negotiated so that we can better tell their story. This has been fascinating to me to learn from patients why they are on a selected therapy, what their doctor decided to do, and why that therapy matters so much to them. We're looking at this a bunch of different ways. I know in my family, for example, I have an experience with a product that's being negotiated. And literally the doctor said to me, well, we have to put your mom on this therapy because you take it twice a day and the other product you take once a day. And your mom is really struggling to control her blood pressure. And this needs to be twice a day. You're really lucky that there's a product that's twice a day that she could be on. So what we want to do is really work with people across the community and individual patients to better capture that story, to really capture what is your experience with this product? Why are you on it? Maybe you are a patient who has disease that is not controlled and you're looking for the development of a product. The only way we're going to be able to help a large agency like CMS understand the implications of this really large law is to better capture those actual patient stories about why this matters. I also think we need to work together and look forward to working with Donna on this to try and improve a way for patients to have a dialogue with the agency about what matters to them. Not just listening, dialoguing. And that's going to be a big step forward.
Thank you. And for those who may not be familiar with health equity and ACS CAN you provide us with a top shelf overview of that, your approach to health equity?
Yeah, so for us, health equity is everything from making sure that we as an organization represent the cancer community, and that means racially, ethnically, sexual orientation, every state in the country. We define every socioeconomic status level. We're really about representing every person that has cancer across all cancers, and cancer is very diverse. And then when we think about health equity, we're really thinking about how we make sure that patients, all patients, have access to care for the therapies they need to survive their cancer. And this is really tricky, right? Because cancer is everything from screening, thinking about maybe you don't have insurance and you need to get screened. So how are you going to make that happen? So we support opportunity for $0 screening, to making sure that when you are being seen by an oncologist, that you have access to insurance, potentially through the Medicaid program, to making sure that you have access to the drugs you need by reducing barriers through utilization management to patients receiving care, all the way into palliative care, making sure that you have symptom management throughout your journey. And at each step of the way, we are asking ourselves, are we being representative of all the people who have cancer? Right now in the United States of America, we have 18 million cancer survivors. So that's people from diagnosis all the way through post-treatment. So we're really thinking about this really large universe of people. How do we better represent them to make sure that we are telling the story of, Native Americans potentially living in the West, or it could be someone who's living in Chicago, or it could be somebody that's living in Florida, and everywhere in between, to tell those stories, because cancer, like many diseases, is very, very diverse, right? And we wouldn't be doing a good service if we weren't really thinking about how we can make sure that we resolve disparities with a goal towards achieving health equity.
Thank you for that, Pam. And as we end our time today, I have a direct question for each of our esteemed speakers. We'll start with you, Pam, and turn to Donna and Stephanie. Considering the current implementation of the IRA, I'm curious to know what actions our participants, our collective network of patients, clinicians, researchers, and community leaders can take right now to prioritize health equity and ensure that the value of the patient remains at the forefront. And we take about 5 minutes each.
Sure. So I think that that's a really interesting question. I think the number one thing you should do, and you're starting by participating in this webinar today, is get educated, right? It sounds confusing. They didn't name this bill the sexiest of names. I continue to explain to people that this has nothing to do with retirement. To really get involved, to learn more about what this law could potentially mean to you and to the community that you're in, and then to activate. There are many organizations that are actively involved in telling the patient's story and what it means in the development of new drugs, in accessing new drugs, in surviving a particular disease. And we really do need every single story that we can collect. I think Donna and I could probably regale you with so many stories where we've had maybe just one or two patients who've been brave enough to raise their hand, or maybe they're a caregiver, and tell a story. And we've been able to take that to a legislator or to someone in government and say, look, I know you don't want to hear this, but can you just listen to this story? And they hear the story and they say, wait a minute, this is a real problem. In fact, just this week, the Secretary of Health and Human Services was on Capitol Hill. It's a very contentious conversation. And he said, I don't believe that this policy that we're talking about is that patients are being negatively impacted. And the member of Congress said, yeah, well, guess what? We're going to flood you with a bunch of stories because you're wrong and you don't know. So it's our job to make sure that people know about how these laws impact us. We really have to unite and to just tell our stories. It doesn't have to be all the, health economics and value and everything like that. It has to be really talking about your story. Why does a particular drug matter to you? Maybe you were on another drug and you got switched. Why? Why is it better for you? Why is it worse? These are really simple stories, honestly, that people can tell. And when you work with a patient advocacy organization, we're really able to tell those stories and amplify your voice to make change. The last thing I'll say is something that's really important, and I think it's something that we take for granted here in this country. We live in a representative democracy. What does that mean? That means that we elect people into governmental bodies to represent the American public. But they can't represent us if they don't hear from us and they don't hear our stories and our concerns. So really, I would implore you to get involved and to get engaged, to not think that your story doesn't matter. every one of us has a healthcare story. Like I said, even as I was working on the Inflation Reduction Act, my mom had a serious incident. And when the doctor said what drug she was moving to, I thought, oh my God, well, thank God that drug's around, because it's a negotiated product under the Inflation Reduction Act. And I thought, well, Mom, thank God, thank God that drug's still out there now, because we can get it and it's really going to improve the quality of your life. But these things happen to all of us. And so I think really thinking hard about how you engage and tell your story is really important.
That's great, Pam. We're all expert in ourselves. Donna?
I was listening to an interview with Jeff Bezos, the founder of Amazon, and he gave an example from their own, operational reports, that if the data and the stories are in conflict, believe the story. Because maybe you're not measuring the right thing, or maybe you're not looking at it the right way. And so I think that sometimes story can be underestimated, or we just think it's sort of a fluffy type of thing. But what we're really doing in detailing and articulating our experience and their impact on our lives from healthcare is giving people insights into windows that they would never otherwise have the opportunity to have to understand. I remember going from a position where I was in front of the Senate staffers and congressional staffers, every day creating legislation, and then going, from a Friday and starting a new job on a Monday, where I was in offices at hospitals and health systems, talking to chief nursing officers and CEOs of hospitals, and seeing the impact of what we were passing on people who actually had to implement it on the ground in real life, in reality, was game changing to me, eye opening about how I thought through things. And so I don't want anybody listening to this to think that their story, their experience is of little value. And sometimes it's the only thing that can make a difference. I think the responsibility of patient advocacy organizations to as Pam said, to educate and inform, and to break down these issues and the ways to share your story, the ways to participate, to bring that information into communities, rather than expecting them to read the Federal Register or to access this information in the ways that we do. I think it's our responsibility and our privilege to be able to go into communities, and whether that's churches or Kiwanis meetings, or on HBCU campuses, or at community clinics or parks or schools, and bring this information to where people are, and put this information in the flow of their lives, and make it easy for them to record their story for us to use, or to share it in a social media way that we can then package and leverage. And so I think it's incumbent upon us to, if we're going to make sure that as many diverse voices are heard, and as many experiences are able to inform the insights of this process, then we need to really think creatively, and to work really hard to bring this to people, and make it as easy as possible for them to understand and to participate.
Thank you, Donna. Stephanie?
Yeah, Pam, I would leave everyone with sort of 3 high-level points. One, I would say that, let's keep our eyes wide open. The president and some members of Congress are touting IRA as a win against the drug and biopharm industry, where the reality is we've never seen it as a fight, right? The biopharm industry has always been willing participants in doing what's right for patients and guaranteeing patient access. I'm a registered nurse by background, and working in this industry has been a privilege because of that innovation. So the action or the takeaway there is let members of Congress know that you're willing to protect patient innovation and you want to preserve physician-patient choice. And when you think of the minority community, cardiovascular disease, mental health disease, neurology, infectious disease, cancers, rare diseases, these are all, these R&D and innovation centers are going to be sort of sub-optimal packs, if you will, substantial, impacts of the IRA. Secondly, as Pam stated, price setting does not change what patients experience at the counter today. Congress missed that point. And so action there, I would say, and double down on Pam and Deborah and say, just weigh in on the smoothing and the processes and the clarity where education is needed and ensure that it's implemented in a manner that keeps patients first. And then lastly, the guardrails. Congress and CMS, it's implementing, must ensure guardrails are in place to ensure patient access, quite frankly, not just government savings. So the action there would be, once negotiated, how do we ensure that third-party payers and PBMs allow continued access and that those access rules aren't put in place or changed? So let your concerns be known. Look out for switching of your medication. Is a drug still on formulary? Have the tiers been changed? Are you paying more? Is your access to that product no longer available? And ensure that, the policymakers at CMS as well as members of Congress know about it. So that would be my sort of 1, 2, 3, if you will.
And thank you, Stephanie. So as we conclude today's webinar, I want to give a heartfelt thank you to our esteemed panelists who have generously shared their expertise with us. To our attendees, thank you for your participation. Thank you for joining us. We hope you leave with new perspectives and ideas that will inspire your work going forward. Please keep an eye out for future events. Brandon mentioned at the beginning of this webinar that we have a session at the National Minority Quality Forum Summit on the health policy landscape. So keep your eye out for that. Your participation is what makes our community thrive. So with that, I say thank you to all. Have a great afternoon. Goodbye.